we doing today? As you already know, we're continuing our regional anatomy series and we're going to be focusing on the vertebrae. Now this is quite a complex one to begin with. Now each vertebra itself is quite complex, so before we get started, let's go over some few fundamental areas in the vertebrae. So as you can see here in this photo, we have the vertebral column, and it's made up of 4 distinct parts: cervical vertebrae, the thoracic vertebrae, and the lumbar vertebrae, as well as the sacral vertebrae down here. Now you can see the 2 and then the degree and the 1 and the degree, and what that stands for is this is secondary and this is primary. So secondary flexure, primary flexure. And they get these secondary and primary names from the actual position they were at birth. So if we zoom in here, we can see that in the fetus, we can see all bones, a concave side is pointing in towards the body. If we look as we grow, we get more convex sides pointing into the body here. So the convex sides that point into the body are known as secondary flexures, and the concave sides, like the thoracic and the sacral, are called primary flexures because they follow the traditional curvature when we were in the fetus, whereas we can see the cervical and the lumbar vertebrae both follow different directions compared to what they were in the fetus. Now here's a look of the bone version of it. We can see that the thoracic vertebrae are essentially where the ribs are, because every single rib attaches to a thoracic vertebrae. Now this is the last thoracic vertebrae here, T12, and it connects to the 12th rib. Now within each part, each segment, there's actually specific types of vertebrae. So we have what we call atypical vertebrae and typical vertebrae. So typical vertebrae are the majority of the vertebrae. They all have a very same size, same shape, same features. Atypical vertebrae have specialized features to suit the needs of their specific location. Now here we have a photo of a standard typical vertebrae. So not all typical vertebrae look the same. Some have very specific features according to their specific section, but in general they have these main features. So they all have a vertebral body, which is the largest part, which has the most bone. Okay, we can see from top view it kind of looks heart-shaped, and the size of that vertebral body changes depending on which part of the spine you are at, but overall they're all about the same shape. We've also got these pedicles. Now the pedicle connects the vertebral body to the vertebral arch, which is this big arch here that has the transverse processes. It also has this spinous process that points out the back, and you can actually palpate this. If you follow your spine down, all those bumps that you're feeling are the spinous processes that point out posteriorly in the back. Additionally, we have multiple articulating facets. Now the position and the function of these articulating facets actually change depending on the section you are in the spine, but we'll get more into that later in the video. Here we have our first atypical vertebrae. This is known as the atlas, and it's actually the first vertebrae going from top to bottom in the whole spine. It's called C1 vertebrae. Now as you can see, this is quite a bit different from the previous photo I showed you of the typical vertebrae. Its foramen is a lot bigger. It's also got these flat and large superior articulating facets, as well as an anterior facet up here. Now all these facets play a special part in neck rotation and mobility. These 2 facets up here are called the facets for the occipital condyle, because this is where the occipital bone, which is the bone at the back of your head, rotates with the spine. This facet here is known as the facet for the dens. Once we get onto the axis, which is our C2 vertebrae, it has this little facet for articulation with the dens of the C2, and this allows for a synovial pivot joint and allows rotation of our neck like this. You'll also notice that unlike the previous vertebrae, which was a typical vertebrae, this has a much smaller spinous process. In fact, it doesn't really have one. We call it a posterior tubercle because it's barely a process in this case. It's very small and it needs to be so it can rotate effectively with the neck. Now another very, very important feature that is only common to cervical vertebrae is this foramen transversarium. These 2 holes on either side of the vertebrae, both lateral sides of the vertebrae. What these allow is for passageways for our vertebral arteries and our vertebral nerves. So very important structures, and without them there would be no guidance, and they also may be subject to any impact around the neck. And without vertebral arteries, we would have no blood going to our spine, which, as you know, is not beneficial. Now if we zoom in on the top of the spine, we can actually see it here. We can see our C1, the atlas, articulating with our axis bone down here with the dens. Now, fun fact, the reason why it's actually called the Atlas is because in Greek mythology, Atlas is a large titan that was tasked to hold up the earth and the heavens. And in this case, our head is considered the earth, and that bone holds up our head. So that's why they're called the Atlas. Fun fact. Now, the reason why C2 is called the axis is because that's what it spins on. It spins on the axis of the world. So it's the center line. The same way the earth spins on this axis, our neck spins on that axis too. Now, moving on to C2, so we can see C2 vertebrae, and we can see that dens far more clearly, okay? And on that dens, we can also see these two facets for the attachment of the alar ligament. Now, that alar ligament prevents over-rotation of our neck and preventing further damage. Now, once we get to the ligaments, I'll pull up a photo, but for now, that's all we need to know. We can also see the emergence of some spinous processes. And so we've got quite a small one here, but it's still large enough to know it's a C2. Now, it doesn't look like this has a foramen transversarium, but C2 does actually have a foramen transversarium, but it's under this articulating facet for the atlas. It's right under there in this hole. Now we're going on to our first typical vertebrae. So typical vertebrae, once I said, are the general shaped vertebrae of that section. So a typical cervical vertebrae actually looks like this right here. You've got a large spinous process. Note that it is bifid, which is unique to the cervical vertebrae. It's got a bifid spinous process, which means two ends. All right. We've got quite thin lamina here, but we've also got these transverse articulating facets, as well as transverse processes here. Once again, you can see the foramen transversarium, which holds the vertebral artery and nerve, as well as quite a small vertebral body here. Another unique feature for all cervical vertebrae is this uncinate process right here. Now, unlike the lumbar vertebrae, which has a large body for stability, or the thoracic vertebrae, which have the ribs and the articulating demifacets, the cervical vertebrae has neither of those. It's got quite a small body and it has no articulating facets for ribs for stability. So instead, it has these uncinate processes, and these are very important both because cervical vertebrae is the most mobile part of our spine. It can perform all types of movements such as flexion, extension, as well as lateral flexion and circumduction. Now the cervical vertebrae has one final vertebrae that's atypical in shape. We can see that compared to the before, this one's got a large, much larger spinous process, but a much smaller sacral foramen, as well as a much smaller body. It's still got the foramen transversarium, but they're a lot smaller than the other ones that we saw in previous vertebrae. Now, the reason why C7 is so special is because it marks the transfer between two sections in the spine. It goes from the cervical spine down to the thoracic spine, and thus it needs to combine the traits of both. The thoracic spine moves a lot less than the cervical spine, and so in order to maintain that stability in the thoracic spine, the cervical spine needs to act in a similar way. As such, this C7 has this large spinous process, which is characteristic of thoracic vertebrae. It also has very small foramen transversarium because it doesn't actually carry the vertebral artery down here anymore. Now, fun fact, if you bend your neck forward like this and run your finger right down your neck, the first large bump that you feel will be a really large one, the one that sticks out the most. That's going to be your C7 vertebrae. And it's a lot easier to do it when your neck is in flexion. Here's a good photo of it. If you run your finger down the nuchal groove, there will be a slight bump here, but keep on going to this large process right here, and that'll be your C7 vertebrae. Now you can then go on to feel T1, T2, and the rest of the thoracic vertebrae, but that is a major landmark, especially in medical science. Now, moving on to thoracic vertebrae. Thoracic vertebrae are quite complex in their role. So as you can see, the ribs actually have to attach to the thoracic vertebrae, but if we zoom in on them, each rib attaches to both the vertebrae above it and the vertebrae below it, making the design of these vertebrae quite specialized. Now, before I move on, I just want to clear the numbering system out of the way. If I have the second rib, then the second vertebrae will be the vertebrae directly below it. So this one right here. Moving on to the actual shape of these thoracic vertebrae, we can see they have a lot more articulating facets to combat with those ribs that we will be moving a lot during exhalation and inhalation, as well as just everyday movement. Now we can see the vertebral body of these thoracics are quite a bit larger than that of the cervical spine because it needs more stability. It also has a lot more facets that need to be available, especially for rib mobility. Now we can see here we've got what's called a demifacet. Now the reason they call it demifacet is because it's half. It's half a facet because only half the rib is actually attaching to this vertebra, as I just showed you before. So we've got the superior demifacet for the articulation of its own rib, and then the inferior demifacet, which articulates with the rib below it. We've also got this facet for articulation with the tubercle of its own rib. So what will happen is the rib will attach here, at least the bottom facet of it will attach here. It'll come across and a part of the rib's neck will also attach here. The neck has this tubercle on it, which I'll show you later, and it articulates with this facet of articulation in this tubercle. Now, like pretty much every other vertebra, it's also got the superior facet and the inferior facet, as well as the inferior notch that sits right here. You can also see the continuation of quite a large spinous process, which you can palpate pretty much all the way down your back. However, thoracic vertebrae still have some atypical vertebrae. Now, the atypical vertebrae in the thoracic region is the first thoracic vertebrae, so T1, and the T10 to T12, so these three down here. Now, the reason why is due to their facets. If we look at T1, it's only got one facet. If we look at T10, it's only got one facet, same as T11 and T12. It's got no demifacets. Whereas T9, which is a typical vertebrae, has a demifacet inferiorly and superiorly. Now the reason for this is because T11 and 12 have what's called a floating rib. And because of this, they don't need to articulate with both top and bottom vertebra. Now I can actually show you this on our visual anatomy system over here. We can see that generally a rib articulates with both the top and the bottom vertebra. But if we go down to T12, we can see that this rib is only articulating with one vertebra. And that's what makes those thoracic vertebrae atypical, is because they have those different facets traditionally to what we expect of a thoracic vertebra. Now, our final unfused vertebra is the lumbar vertebra. The lumbar vertebra have these two special processes called mammillary processes, and they help with stability of the lumbar. Now the lumbar can move quite a bit. It can move side to side as well as forward and back in flexion and extension, but these mammillary processes help stabilize it during that process. Now we've also got this spinous process, and in contrast to our thoracic vertebrae, which have a spinous process that point sharply down, these point sharply posteriorly. So it's pretty much the same as a typical vertebrae, the standard typical vertebrae. However, it's just got these mammillary processes. So it's still considered a typical vertebrae. However, L5, which is the final lumbar vertebrae, has this special facet for articulation to articulate with the vertebra of the sacrum. And it's got this little fin right here. Now that makes this lumbar vertebrae an atypical vertebrae because it's unlike all the other vertebrae that we have here. And it's the only vertebrae that articulates with the sacrum. Now you'll find a pattern here. Most of the vertebrae that are atypical are found either on the end or the start of the specific section in the vertebrae. And it's because it requires the transfer between one vertebra to another, because each section has a slightly different type of vertebrae for their specialized controls. Now moving on to our fused vertebrae, it's all fused together, and in that fusion we have the sacrum. Okay, and because of this fuse we have a couple of facets to articulate. So this facet here articulates with the pelvic bone, specifically the iliac of the pelvic bone. That's why this makes up the sacroiliac joint. It's also got this superior facet which articulates with the L5. We can also see these holes here, or the foramen. So this is called the anterior sacral foramen, which allows spinal nerves to pass through, which is very important. We've also got a posterior sacral canal. Now I can't really show you on this photo, but if I go over to this model over here, you can kind of see a canal that passes through there. Now spinal cords don't actually pass through here. However, what does pass through here is the cauda equina, which is like a horsetail-like structure, which is where the nerves of the spinal cord actually split and they go through this. And there's actually a special cord that runs between the cauda equina, called the filum terminale, that anchors to the coccyx and prevents the spinal cord from moving too much and damaging any nerves in the process, or ganglions for that matter. Now, our final fused vertebra is the coccygeal vertebra. As you can see, it's made up of 4, sometimes 3 vertebrae. It actually differs on some people. And you've got these 2 little horns here called cornua, and that's pretty much all you need to know for now. This is otherwise known as the tailbone. Now, when you say you've broken your tailbone, you've actually broken this little guy right here. Let's get on to the more interesting stuff, which is types of flexion in our spine. So as we can see here, this first lady is representation of normal flexion in our spine. So we've got the secondary cervical flexure, we've got the primary thoracic flexure, we've got the secondary lumbar flexure, and the primary sacro-coccygeal flexure here. Okay, we can see that as we get older, sometimes we may begin to hunch, right? Anytime our spine bends forward anteriorly, that's called kyphosis. Okay, and when we have excessive kyphosis, we call it hyphosis. All right, and this lady here, she's got excessive kyphosis, but in more extreme progressions and cases, you can get hyphosis, which is like almost like a gamer's neck, if you've ever seen one of those before. And yeah, it can also reduce your height. So when people say they shrink, that's usually the reason why, is because they've undergone some sort of kyphosis or lordosis. Lordosis is when the spine bends posteriorly. Okay, we can see here in this case, the lumbar part of our spine has got excessive lordosis compared to the natural state of our spine, which causes a little bit of an arc in our back. Now, in terms of lateral flexion in our spine, generally our spine, if we look at it from a posterior view, should be straight, like this woman right here. However, if you've ever heard of scoliosis, what scoliosis is abnormal lateral flexion in the spine. We can see here in this woman, she's got abnormal lateral flexion to the left, right? Her spine pokes out to the left a bit. Now, this can affect someone's balance and weight distribution, as we can see the weight line actually meant to point straight down. But now in this lady, it's actually pointing a bit of side to side, and it will cause the vertebra to not be as stable, which is bad for normal movement. Now, furthering on our thoracic region, we're actually going to move on to a new bone, which is the ribs. We can see that the general shape of a rib, as you know, it's like a crescent. It's like a half moon. They all have flat kind of face here, and then they've got this angle, which causes a sharp turn in the rib, and they come around and then they connect to coastal cartilage, and that coastal cartilage will actually connect to our sternum, at least for the ribs that connect to the sternum. Now, in terms of the parts of our ribs, we've got the head of the rib, which is pretty self-explanatory. It's the start of it, which flexes with our vertebra. Now, you remember how I was explaining that vertebra has that extra facet for articulation with the rib? This tubercle right here on the rib is what articulates with that facet and allows the rib to be a bit more stable during its bucket handle motion in breathing. Now, as I said before, we've got an angle here, and at this angle, quite a sharp bit of flexion occurs. We can probably better see this on our diagram. We can see that the rib kind of comes out straight, and then we can see this line right here, and it starts curving very, very hard. And that's called our angle of the rib. Now, coming back to our rib, we've got a couple of things. So we've got this internal concave surface, and in that internal concave surface, we've got this coastal groove that runs here. What that allows is for coastal nerves and coastal veins to actually pass through and be shielded, especially because the ribs, you can pretty much feel them, right? Imagine if the vein or artery was right on the outside and you got impacted. It would hurt a lot more if that vein was on the outside rather than protected by this groove on the inside. Now, I've also got the external concave surface, and then we've also got this coastal cartilage, which it connects to. Here's a better look of the other side of the rib. We can see that articulating facet. That articulating facet sits on that tubercle I was talking about earlier. Now, in terms of the articulating facets with the vertebra, a standard rib actually has two articulating facets that articulate the vertebra. Remember how I said the ribs articulate with two vertebrae. At least normally they articulate with two vertebrae. So this would articulate with the inferior facet of the above vertebra, and this would articulate with the demifacet of the below vertebra, or the inferior vertebra. Now between these two facets we have a crest to separate them and increase joint congruency, which is very nice. Now a couple of important terms there's a couple of important terms we need to know for the ribs. So we've got this costal cartilage, which is the blue stuff here. Okay, it's not actually rib, it's made up of hyaline cartilage. We've also got the intercostal space, which is between each rib. If we palpate our sternum and we start at the manubrium, okay, we can actually feel down, and then we can feel a little drop as our sternal angle comes around, and we can feel that change in angle there. And that is actually our sternal angle, which is pretty cool. And it's just a good palpating tip. It's actually a very good skill to have, to know how to palpate bones in the body. We've also got this infrasternal angle. So the infrasternal angle is the angle made by the costal cartilage right here. You can actually feel it. If you suck in your tummy a bit, you can stick your fingers up underneath that costal cartilage and that infrasternal angle and feel around a little. Now it feels a bit weird, but it's good palpation technique. It's not too hard to feel, and it's pretty cool. Now, like vertebra, we've also got atypical ribs. Okay, so atypical ribs are ones that have a single articulating facet, or they're got a different size, different shape. Now if we go to our first rib only has a single facet, and it's actually very small, and it's got a very, very big curve on it compared to all the others. If I actually go back to the rib, you can kind of see it. Okay, we can see that our first rib has got a lot more curvature than all the other ones. It curves a lot faster too, and it only articulates with one of the vertebrae, which is the first thoracic vertebra, and that's why it's an atypical rib. We've also got rib 12, which also is an atypical rib. Same with rib 11 and rib 10. The reason why is because they only have one articulating facet to articulate with the vertebra, because remember, our T10 to T12 are both atypical vertebrae, and they only have one articulating facet each. If I increase the amount of connective tissue, we can see that T12 and T11 are floating ribs, and they float by themselves, whereas T10, T9, T8, and T7 all share cartilage and connect on the last facet on the body of the sternum. Now, another important feature of our atypical ribs, specifically our rib 1, is these grooves here. Now, these grooves are special for some nerves and arteries that pass through, specifically the subclavian artery and nerve. And we've also got this scalene tubercle, which helps with muscle attachment. Now, moving on to the sternum, we can see all the facets where the ribs actually connect and articulate, specifically the costal cartilages that connect to each ribs. So we've got our articulating for rib 1, rib 2, rib 3, 4, 5, 6, and then rib 7, 8, 9, 10, etc. Now, if for those who don't know, the sternum is actually made up of 3 distinct parts: the manubrium, which is our uppermost part, the body, which is the largest, longest part, and then our xiphoid process, which we can actually palpate. It's right where the sternal angle meets, and you can kind of feel it if you put your finger up there. Now, if we put that all together for a typical rib, we can see our rib connects to the demifacets of these vertebrae, curves around, and then it connects to a single articulating facet. Specifically, this one articulates with the body of our sternum. Now, that wraps up all the bones for the thorax pretty much, and our cervical spine. Now we're going to actually move on to our ligaments, which play a super important role, specifically in protecting our nerves and balance. Now, the first ligament I want to talk about is the posterior longitudinal ligament. Now, it passes through the vertebral canal that runs through the vertebral foramen of each of the vertebrae, and it passes in the... Now, moving on to the posterior longitudinal ligament, this runs posteriorly to the vertebral body, but anterior to the vertebral arch. We can see it actually runs through the spinal canal down here, and what it helps with is it actually prevents overflexion. When we move forward, what's going to happen is there's going to be tension in that posterior longitudinal ligament, so when we bend forward like this, and it's going to prevent us from overflexing our spine. The reason why that's so crucial is because if we overflex our spine and we pull on our spinal cord, then that's paralysis for you. You know, it wouldn't be a very good feeling. I can tell you that for free. Now, similarly, the anterior longitudinal ligament does the exact same thing, except during flexion. So when we flex our backs back like this, it's going to prevent us from over-flexing and hurting our spine. Now, this diagram here has quite a few ligaments that we got to go through. Now, another very important ligament is this interspinous ligament, and it goes between the spines of each of the vertebrae. A better way to look at it is if we go to our model, we can see that there's a ligament that kind of looks like the back of a fish, like those fins on the back of a fish, but it's actually the infraspinous ligament, and it goes through each of the spines. Additionally, there's also a supraspinous ligament because it actually runs up, or it runs up the spine of each of the vertebrae, and we can see it here. It's like this little tube-like structure that runs up and down at the tip of the spines on our vertebrae. Finally, another very important ligament is this ligament here, and it kind of a continuation of that infraspinous ligament, but quite a bit larger, and it's called the nuchal ligament, and it plays an important role in stabilizing the cervical vertebrae, as well as an important site for muscle attachment, such as the trapezoid muscle. We can see here it runs all the way down from our external occipital protuberance all the way down to C7. Now, it's a bit hard to see this ligament here on our models, so I showed you a photo here. It's called the transverse ligament of the alar, and what it does is it pushes the dens towards the anterior arch of our C1 atlas, and that stabilizes and allows rotation of our joints between the dens of the axis and the atlas. This is known as the medial atlantoaxial joint. And that, my friends, finishes it off today. I hope you enjoyed this video and learned a bit out of it. Let me know if I missed anything or if you want me to cover anything again. Also, please don't hesitate to identify any mistakes in the comments. Other than that, have a fabulous day, and I'll see you guys in the next video.